My name is Chris Petrick, and welcome to everyone today. We're going to talk about understanding the world of dementia. A little bit about myself. I'm a registered nurse. I've been a registered nurse for over 40 years. I've worked in various areas of healthcare and education in healthcare, and have spent my last about 18 years in elder care. So I am a dementia care specialist, and I'm also a certified instructor, and I am a dementia reality master trainer. Dementia Reality is an awesome program that was developed by Elderwerks and CJE that takes virtual reality and not only does education for the professional caregivers, but we do training for anybody who's caregiving at home. So today we're going to talk a little bit about the world of dementia. And I don't know why those things keep coming back. There we go. So these are our objectives today. We're going to talk about Alzheimer's disease and Alzheimer's disease related dementia, what is normal versus non-normal, reversible types of dementia, irreversible, some brain changes, which I think is important to talk about with dementia, recognizing how dementia affects people differently and communicating with them. Those are the important things that we need to know when we're talking about someone who's living with dementia. These are some of our facts and figures, and you can find these on the Alzheimer's website. And these are their facts and figures. There's some great and very interesting statistics available that you can find in their annual report. And as we know, the 2025 statistics show that Americans age 65 and older, almost 7 million, are living with Alzheimer's disease. Over 73% are age 75 and older. And of the most 7 million people age 65 and older with Alzheimer's disease in the United States, 4.1 million are women and 2.6 million are men. Now, I often get asked, why do all women get Alzheimer's disease more than males? And they don't really know why, but they feel that because women live longer than men, men usually die of more of heart disease in those early stages of older adulthood. And women tend to live on a little bit longer. Some of it might be hormonal, but we're going to talk about the reasons that people get Alzheimer's disease and what we can do about it. So I think the first thing that we need to distinguish is what normal aging is versus mild cognitive impairment versus dementia. And during normal aging, the body gradually slows down, but our intelligence remains stable. However, a person with mild cognitive impairment may have significant problems with memory or some other core functions, but impairments are not significant enough to interfere with daily life. There's two things that you may hear in this arena of older adult care, and you'll hear ADLs, which is activities of daily living, and IADLs, independent activities of daily living. And to differentiate between the two, activities of daily living is what takes care of our personal issues like bathing and toileting, getting our teeth brushed, combing our hair. Independent activities of daily living are things that keep us kind of moving forward in our life every day: shopping, cleaning, socializing, planning, driving a car. So there's many things in the instrumental activities of daily living. And we may find that people with mild cognitive impairment, or MCI, may start to have some issues with those things. Now, it's not enough for many people not to live independently. As a matter of fact, many people with mild cognitive impairment live independently. They just need some support systems. One of the things they'll do is they'll write themselves notes, post-it notes, and write things down, a grocery list. Think about a grocery list when you went to the store when you were 20 and you could remember the 5 things on the list. Now the 5 things on our list start to drop off as we get older. So we start using things that help us kind of live independently. And we may even depend on our family for things. One of the key things that you'll find that people with mild cognitive impairment may need help with is paying their bills. Finances, when you start to see finances starting to change and they start to fall off, that's probably a significant clue that we're having some problems. If we talk about dementia, is now what we call major neurodegenerative brain disorders. There's a book of the mental health guidelines, and it's the MSD1. And that actually will give you diagnoses based on symptoms. And if you looked at that book from 15 years ago, it was coded as dementia. Now it's coded as major neurodegenerative brain disorders. And the reason they changed that in that book is because there's a lot of stigma when we talk about dementia. The original dementia made us think that people were crazy. And this is not someone being crazy. This is someone who has a major neurodegenerative brain disorder. But in our presentations, we use dementia because that is the most common term that you'll hear out there. At any rate, persons living with dementia have serious enough mental decline to interfere with their daily life. And again, we'll talk about Alzheimer's disease in particular, that has stages. They may still be able to live independently with many support services in the early stages of dementia, along with mild cognitive impairment. But as the disease progresses and it interferes more and more with their daily life, and it includes their ADLs, their activities of daily living, that's when we know that they probably are not able to live independently anymore. Many factors are considered in a differential diagnosis between natural aging and dementia. Now, many of you, myself included, if you have not been to the doctor recently, they do a very perfunctory test in the office for dementia. They may ask you to remember 3 words that they say. They may ask you to count back from 100 by 7. That kind of scares me because I'm not a math person. And they may ask you to draw a clock. Those 3 things are pretty telling about whether that person is cognitively intact or they're starting to move towards that arena of dementia. It's not a diagnosis, but it kind of gives us some ideas. When we talk about normal aging, it's characterized by, like I said, a general slowing of cognitive performance. And older adults typically perform worse than younger adults on tasks of attention and episodic and working memory. But they do better on tests of general knowledge than younger people. So if you remember that game, I'm not smarter than a 5th grader. Usually the 5th grader did better than the adult. And why was that? Think of your brain. Someone explained it to me like this. I'm a visual person and it made sense. Think of a brain of a young person as a file, well, all of our brains as a file cabinet. And their brains their file cabinets don't have a lot of information in it yet, just what they're taught in school, taught at home, maybe some life experiences. But the adult, and particularly the older adult, their file cabinets are pretty full. So when we are asked to retrieve something from that file cabinet of our brain, the younger person might be able to pull that out very quickly. because there's a lot of room in there and they can see the files. But as older adults, because we've lived a life, our file cabinets are full. And if they're full, a lot of times it takes a little bit of time for that to process and pull out that information that we have in our brain. I hope that's a visual that will stay with you. So we have a general slowing of cognitive execution. We have a decline in mental flexibility. One of the things that we can do to keep ourselves thinking young is to become a little more flexible. Think outside the box. Every day you have dinner at 5 o'clock, and if 5 o'clock rolls around and you're not having dinner, you might get upset about it. It changes your whole world for that evening. But we need to really think about being a little flexible about that, because that helps us build more synapses in our brain. And we'll talk about what synapses are and neurons. Some people struggle finding the right word. Now, the difference between someone with dementia finding the right word and someone in the normal aging process, and I did this just the other day because I'm an older adult, is I couldn't think of the right word right away because it takes a little more time. Remember, my file cabinet is full. However, 30 to 60 seconds later, I was able to recall that word. When you have dementia, you're unable to recall that word because the brain is not working like it should because it's diseased. There's a slight decrease in short-term memory. There may be, you're very well intact for current events. You know what's going on in the world. But you might have a problem pulling out what you had for breakfast on Saturday morning. That would be something that would be short-term memory. In normal aging, you're going to have independence in both your activities of daily living and your independent activities of daily living. And lastly, you're going to hold your verbal and your vocabulary, verbal ability and your vocabulary. So that's normal aging. And then we move on to some of the impairments that we see in our senses. As we age, it does become more difficult to see and hear with the same clarity that we had in our younger years. Impairments in vision, we may have some impairment in speech and hearing, are common in normal aging. Conditions such as cataracts, glaucoma, and hearing are common in normal aging. Conditions like cataracts and glaucoma and age-related macular degeneration, you'll see more frequently. But you'll also see declines in auditory processes and cognitive ability, that in language. You will also see changes in taste and smell. And as a matter of fact, there is some studies that they're doing that say, and it's not a clinical diagnosis, but they do say that a change in smell may be an indication, a loss of your smell, a decline in it, might be an indication of Alzheimer's disease. Again, not diagnosing it on that, just something that happens. So identifying the difference between normal aging and dementia, there is some suspicion and recognition of dementia versus normal aging that are founded on changes that occur across those capabilities, our cognitive function. If we look at what we call our wheel of function, which is our senses, our emotions, and things like that, that make us kind of a full functioning person, cognition is the driver of that wheel. So once you start to lose cognition, you're going to have some other sensory changes. You're going to have some changes in language skills. You're going to have changes in your ability to perform your activities of daily living. And you may see some other changes, maybe some changes in behavior and psychological symptoms. But those happen with dementia, and we don't see some of those changes in normal aging. The ones that are in normal aging are really a little bit of what I spoke of already. So again, mild cognitive impairment is usually marked by problems with memory, language, judgment, and thinking, problems greater than expected for a person of our age group, but less than is required for a dementia diagnosis. The person with mild cognitive impairment typically can still carry out everyday activities, but sometimes their symptoms may be noticeable for families and friends. I had a mother that died from Alzheimer's disease, and 1 in 9 people who have mild cognitive impairment will go on to Alzheimer's disease or related dementia. And what we noticed for her, what was the changes in her, she stopped socializing or decreased her socialization. We also noticed in this mild cognitive impairment, kind of heading into dementia, that she was having problems with her bills, and maybe not, the house was not the tidiest, but we were there to support her, and she was able to live independently for a little bit longer. Keep in mind that I said 1 in 9, but not all mild cognitive impairment is going to progress to dementia. Some people with mild cognitive impairment really can return to normal cognitive abilities instead of progressing to dementia. And mild cognitive impairment progresses to dementia at a rate of approximately 10 to 20% a year. So what is dementia? Dementia is not a specific disease. It's a term for a group of symptoms that can be caused by several disorders that affect the brain. People with dementia have notably impaired cognitive functioning, and that interferes with normal activities and relationships. They are going to lose their ability to problem solve, maintain emotional control for some. They may have some personality changes, and they may have behavioral problems. Memory loss is the most common symptom, but it does not alone mean a person has dementia. And there's different types of dementia that we're going to talk about, that the change in memory, a loss of memory, is not one of the first signs. It's probably one of the first signs for dementia or for Alzheimer's disease, but not some of the other ones that we'll talk about today. To be diagnosed, a person must have deficits in 2 or more brain functions. That would be memory, language skills, or sensory, without a loss of consciousness. So what is the difference between dementia and Alzheimer's disease? The term dementia and Alzheimer's disease is confusing for some people, because what we do is we use dementia as what we call, and you'll see it in a minute, an umbrella term. Many people feel that they are synonymous, but the 2 words really mean 2 different things. Because dementia is a general term for a decline in mental ability, your cognition, severe enough to interfere with daily life. And we know that Alzheimer's disease is the most common cause or form of dementia. Alzheimer's disease is a specific disease, and dementia is not. So dementia, like I said, is an overall term for a particular group of symptoms. Think of dementia as a broad umbrella term that we see here that covers a group of symptoms. The characteristic symptoms of dementia are loss of memory, judgment, language, complex motor skills, problem solving, and other intellectual functions, such as thinking skills, caused by permanent damage or death of the brain nerve cells, which are called neurons. Dementia is a decline in mental function. It's chronic and progressive. It has no known cure. While Alzheimer's disease is the most common form of dementia, there are several other types. And here under our umbrella, you'll see some of them. Now, depends on who you talk to. Some people say there's 50 forms of dementia, or what we call major neurodegenerative diseases. But these are the most common, and that number of how many there are really depends on what your source is. So we know Alzheimer's disease is 60 to 80% of all dementia cases, kind of tied with Lewy body as vascular dementia. And we'll talk about each one of these individually. And kind of in that tail wing there is frontal temporal dementia with Lewy body and vascular. And then we look at the other diseases such as Parkinson's, Huntington's chorea, Wernicke-Korsakoff syndrome. There's a lot of them out there. Mixed dementia is really saying that there is more than one. Now, the thing that you need to know is there's some medical conditions that can cause you to have changes in memory and cognition temporarily. One of them is a urinary tract infection in older adults. Another is respiratory infections in older adults. Sometimes it's a thyroid problem. It can be dehydration, which we see frequently in older adults. And it could be a metabolic issue. So typically, and we'll talk about diagnosing this, but typically when you present to the doctor with confusion, loss of memory, things that look like dementia, they're going to do a workup on you to make sure that you don't have a urinary tract infection, you don't have a respiratory infection, you don't have a thyroid or a metabolic problem or a lack of vitamin B12 or vitamin D. Those all can change that cognition. Once we fix those things, though, you go back to a normal baseline. If it's truly dementia, there's a steady decline. And each dementia has a different way on how it presents itself and how that disease progresses. So let's talk a little bit about brain changes and how it affects those with dementia. To kind of understand the brain changes, we have to really understand what's going on upstairs in our brain. So in the orange, you're going to see this frontal lobe here. That in our frontal lobe is where we have attention, concentration, and personality. That's where it all originates, is in this frontal lobe right here. Then we have this temporal lobe or temporal lobe. It's pronounced both ways. So if you hear temporal or temporal, they're talking about the same thing. And in this lobe, you have memory and understanding language. Then in the parietal lobe, which is right at the top of your head, you have your senses. You have sense of touch. You have deep perception, depth perception. I'm sorry. You have depth perception. So, think of someone who's driving and they're having difficulty with their parietal lobe. They may not see the car in front of them like you and I see it. Or they may go to sit on a chair thinking it's right behind them, and because their depth perception is off. So again, all these things that go on in our brain that make us right and make us live well every day are starting to change. Then we look at the green part, and that's the occipital lobe. And that is where our vision is stored and created. And then we have the cerebellum, and that's the red. And the red is balance, coordination, and visual perception. So if we have an injury or changes in that, we're someone that might fall often. And they may have problems with their visual perception. Think of a game or a toy that we use with our grandchildren or our children, that little ball or a little box that had shapes, and they were putting the shapes in the right container, the cutout. That really is coming from the cerebellum. And among other places, but that's that primary for visual perception. And then our most important down here is our brainstem. That's what we call our autonomic system. That's breathing, our conscious state, our heart rate, everything that keeps us alive and breathing is going to be down in our brainstem. So now that we kind of understand how our brain works, let's talk about a little bit about Alzheimer's disease. Alzheimer's disease is the most common type of irreversible dementia, and it occurs in about 60 to 80% of dementia cases. It usually, if it starts at 65, the risk of developing Alzheimer's disease is gonna double every 5 years. If you get it 85 or older, the risk is nearly 50% that you're going to be diagnosed with Alzheimer's disease, because now we have a lot of changes in the brain. If you start with Alzheimer's disease before 65, that is called early onset Alzheimer's disease. And I'm sorry, younger, they changed it. It's not early anymore. It's younger onset dementia, Alzheimer's disease. And that has its own problems and risk factors. We won't discuss that today. By 2050, the number of is expected to double. And that's because us baby boomers are getting older. It typically affects 200 to 250,000 people younger than 65. It is the 6th leading cause of death in the United States and the 5th leading cause of death for people over 65. And the time from diagnosis to death can be as little as 3 to 4 years if they're over 80, but as long as 10 years in younger people. My mom was diagnosed at 80. We noticed some changes going probably about 78, and she was diagnosed at I think 81, and she lived till she was 93. The one thing that you're going to hear about Alzheimer's disease or dementia is if you meet one person with dementia, you've met one person with dementia. And what that means is, although there are things that are very similar to these different types of dementia, everybody their brain is different, their disease is going to be different, and you may see things that some people have and other people don't have. We tell you typically what is common in these different forms of dementia, but there might be some changes in that. Now, Alzheimer's disease is a continuous decline. So think of it as a starting point, your diagnosis, and then it's a decline, a steady decline down. The pathology is pretty interesting on Alzheimer's disease. It's caused by changes in the neurons. In Alzheimer's disease, brain cells degenerate and die, and that causes a steady decline in memory and mental function. They have what's called plaques and tangles in the brain, and those are part of Alzheimer's disease. With Alzheimer's disease, brain cells degenerate and die, and that is what causes the steady function. Plaques and tangles in the brain are the differentiating component of Alzheimer's disease. The progress of the disease, like I said, is a steady decline. So this is your neuron, okay? And we see what we call tangles there inside of that neuron. This neuron has no tangles. We see at the end of the neuron, you can't see it real clear here, but we get plaques, these big clumps of what we call amyloid protein, and they clump up. In a normal neuron, these ends here have little hairy things on them, and those are called dendrites. And they connect with other neuron dendrites and at the synapse, and that causes anything you do in your body, anything you do or say, or anything that happens in a normal person who doesn't have dementia is because the little tangly ends of those neurons meet other little tangly ends of the neurons, and they fire, and that causes movement, vision, language, everything that we do. But when we get clumps of this amyloid protein at the end, it can't make those synapses anymore. Think of the inside of your protein, here's another visual for you. Think of the inside of your neuron, not your protein. Think of the inside of your neuron as a fishbowl. And if you had a fishbowl at home, and if you had a fish in it, what are you going to do to make sure that that fish lives? You're going to feed it. You're going to water it. You're going to make sure that it has what it needs to live. Same thing we need to do with the inside of our neuron. We need blood flow. We need oxygen. We need a healthy cell. And when it gets invaded by these tangles, then we're not getting enough oxygen. We're not getting enough blood flow. Now, what causes these amyloid proteins and the tangles? Well, we all have amyloid protein in our body. We have something that creates that, but it starts creating it faster and it becomes clumpier. Also, we are looking at inflammation. We look at brains of people who have Alzheimer's, and we know, and a lot of the other dementias, and we see a lot of inflammation in those brains. So things that cause inflammation in our body, high blood pressure, cardiac disease, diabetes, maybe some other chronic disorders, maybe some autoimmune diseases. These are all things that cause inflammation throughout our body. That's going to cause inflammation in our brain. So we have to think about what we can do. There's not a lot that we can do outside of changing some of the risk factors that we'll talk about. But, looking at your diet, looking at exercise are things that you can help with. I know they're studying the GLP-2s right now, and what they're finding with the GLP-2s is there's less inflammation in the brain. So they're thinking it might be helpful for people with Alzheimer's disease. However, and GLP-2s are some of your diet pills like Zetia and Ozempic and stuff like that. But don't run out and say you want to be on this because you think you have Alzheimer's disease, or you have a family history. But what they're doing is looking at this. Now, I asked a physician at our symposium last week, does the GLP-2s actually reduce the inflammation, or does it get rid of some of those pre-existing conditions like diabetes, and that reduces the inflammation? And they're not quite sure yet, but there's hopeful that there may be changes. This is just a slice of the brain. Whoops, and I knew that was going to happen. I apologize. So this is a slice of the brain. This is a side of the brain that is normal, and this is the side of the brain that has Alzheimer's disease. Hippocampus right down here on both sides. You can see that the hippocampus on the brain that has shrunk because of dementia. Remember, it's not getting food. It's not getting oxygen. It's not getting a blood supply. Our brain normally shrinks as we age, and a brain is normally about 3 pounds. We lose about a half a pound of our brain as we age, but with dementia, we can lose 1 pound to 1.5 pounds of our brain just from the disease itself. And where we make and store our memories is one of the primary places is in this hippocampus. And you can see that it's much smaller than it is over here. And so that's why we lose some of our memories. Now, look at the ventricles on this side and look at the ventricles on this side. The ventricles is, maintains the fluid in our brain and the blood supply. And you can see that they're larger here. The reason I'm pointing this out is, and a doctor, I was at a lecture once and the doctor said this, and I've been one of his followers on this ever since because it made so much sense to me. If a younger person falls and they hit their head and they have a brain bleed, they're going to feel the symptoms almost immediately because you can see there's not a lot of room. There's some, a little in between here, but it's going to cause so much pressure that person's going to throw up. They're going to become unconscious shortly. If there's a brain bleed, In an older adult, because there's more room here in between and in these ventricles, a person who falls and hits their head is not going to have immediate symptoms of a brain bleed. It may take a day or two for them to experience the symptoms. By that time, it may be too late. So anybody out there that falls and hits their head, who's an older adult, should go to the emergency room, should have a CAT scan or an MRI or whatever they order to rule out a brain bleed. I know someone who fell off just a footstool and bumped their head. They were cleaning the lights over their bathroom sink and hit the side of their head on the sink, but fell and broke their wrist, which is what brought them to the emergency room. And the nurse in the ER was smart enough to say, "Did you hit your head?" And she said, "Oh, yes, nothing big deal. I just hit it on the sink." So they sent her for a CAT scan. She ended up in ICU. She had a brain bleed. That brain bleed would not have been diagnosed for in enough time to get her back to health. So again, please, if you're an older adult and you hit your head, you need to go be evaluated at the emergency room. Okay. So let's move on. And I have to move this again because there we go. Okay, that black box will go away. So I did mention some of the risk factors that can cause Alzheimer's disease, and some of them are modifiable. And that means that we can fix those. So traumatic brain injury, substance abuse, increasing our physical activity, learning. Education's important, getting that brain moving, sleeping, at least 7 to 8 hours of uninterrupted sleep is important. You need to get into REM sleep to clear out all those toxins in the brain. A good diet that lacks sugar. I know it's so hard. I'm a sugar person, but really it's bad for our health and it causes a lot of internal inflammation. I know people who are away from sugar and they start eating sugar again and their joints start hurting again. So we know that it's an inflammatory. So diet, a good healthy diet, environmental and life choices, cardiovascular heart, making sure that your blood pressure is at a normal rate, making sure you see your doctor. Socialization. They found out so much about socialization from COVID that it actually causes changes in the brain. It causes changes in the structure of the brain. So socialization helps those neurons synapse. I will tell you that about 200 minutes, not hours, 200 minutes of socialization can change your brain. That's really not a lot. So getting out and socializing. Most cases of Alzheimer's disease and other dementias result from a mix of risk factors. We've got those modifiables. There might be certain medications. There's genetics. There's a family history. And there's our age. So my job, because I have a mother that had Alzheimer's disease, is to make sure that I take care of some of these or all of these modifiable risks. Here again are some of those risk factors. About 78% of adults that reach middle age with Down syndrome are going to be diagnosed with Alzheimer's disease. And they're not quite sure why, but that's the statistics on that, 75 to 78%. Hyperlipidemia is just your cholesterol, keeping your cholesterol down. Smoking causes inflammation in the body. Obesity, again, causes inflammation in the body. Age, being 65 or older, and remember at 80 it doubles. Gender, females more than males. Diagnosis of Alzheimer's of a family member, head trauma, and then Down syndrome. I'm not going to read this slide to you. The only thing I'm going to tell you is right now, We are living in the age in 2025 where they are looking at 27 unique therapies, and we're doing about 100 Alzheimer's Association and anybody who does research. There's about 164 trials out there right now that you can work with. I know one of the biggest, and I'm not promoting one or the other, but Rush has a very good Alzheimer's program where they're doing a lot of studies. Northwestern also has, and University of Chicago all have Alzheimer's, big Alzheimer's programs. So again, if you're looking for someone, I would look at one of those three and see if you can get in to be evaluated and then possibly get into a trial. So with Alzheimer's disease, again, it's about a slow decline, about 10 years, but it kind of depends. And there's memory loss, there's changes in personality. Sometimes in early stage, they may be anxious and non-social because they know there's changes. My mom was very aware that there were some changes. She didn't say it, but one day I asked her, I said, Mom, are you upset? Does it upset you that you can't remember things? And she said, not anymore, because I know I'm going to forget more. I don't know how that made sense to her, but to me, that said she knew what was going on. And so they get very anxious about that. They tend to isolate, not socialize as much because they're trying to hide the fact that there's changes. There's changes in behavior. You might see hoarding, and there might be anxiety and depression in those early stages of Alzheimer's disease. Some loss of words and language. They may have, again, difficulty word finding and difficulty with problem solving. Let me move this again. Sorry about that, everyone. Problem solving, which is like I said, finances. And you'll see changes in their independent and activities of daily living. Then we have vascular dementia. That's caused by blockage or damage to the brain in the vascular system. I'm going to be doing a program on strokes, I believe in June or July. So we'll talk about the different types of strokes. There's the strokes that bleed and there's strokes that clot. Either way, the blood's not going to get that oxygen and blood supply to the brain cells, those neurons. And so for the vascular dementia, it really depends on what the risk factors are. You might see impairment progresses with each additional stroke or vascular insult. Vascular insult being a TIA, which is a precursor to a stroke. It's called a trans-ischemic accident. We know that it progresses in a stair-step formation. So they have their initial insult and they plateau, and then they may have another vascular accident or a stroke. And there's about a 50% chance of having a stroke within the first year of your initial stroke. So it plateaus, then you have a second accident, it drops down, your cognition, your movement may change, and then it plateaus again and it drops down. Because the risk factors for vascular dementia are pretty much the same with Alzheimer's disease, cardiac inflammation, high blood pressure, hyperlipidemia, you may see both of them together. You often see them together. They decline at a slower rate. The lifespan of a person with vascular dementia is 3 to 5 years after the symptom begins. And that's typically if they don't have another stroke. Here's some of the lifestyle risk factors for dementia, vascular dementia: obesity, smoking, lack of physical and activity and exercise, lack of social support, and an unhealthy diet. Most of those are modifiable. And so if you have any of those risk factors, you may want to think about changing those. Here's some of the symptoms of vascular: is memory loss, poor judgment. They may misplace things. You'll see a reduction in their language skills. You'll see some personality changes. That might be one of the first things. Poor judgment is one of those first things, inappropriate behavior and hallucinations, not at the beginning, usually towards the end. Our next one is Lewy body disease dementia, and that results with, we're going back to the brain again, and they are bodies in the brain that are called Lewy bodies. It's the most common form of dementia, so it's similar to plaques and tangles, but they're a different formation. So think of them in that way, but in a different formation. What it does is it occludes the oxygen and the blood supply getting to the brain, but they're Lewy bodies, so they're going to have a different symptom. They're very difficult to diagnose, and the reason is they may have a change in cognition one day that declines, and then the next day they're right back where they are on their normal cognitive level. It can change within hours or days or over days, and so it's difficult to diagnose it. They may start out with a diagnosis of Lewy body. However, memory loss is not one of the first things that you'll see. You might see confusion and alertness that changes within days or over days, changes in gait or imbalance, similar to what we call Parkinson's movements. They will see visualized hallucinations and delusions. They're typically not frightening to them. Their delusions or hallucinations are typically of small animals or children, and they have trouble interpreting visual information. So that's why they're seeing what they see. And again, they'll have memory loss, but it's not as significant. They too will have sleep disturbances. So in our demographics, it's about 1.3 million cases of Lewy body in the United States. It's reportedly a higher number of undiagnosed because they're frequently misdiagnosed. Again, difficult to estimate the prevalence of dementia with Lewy body separately from Parkinson's disease dementia. There is a part of Lewy body that we call Lewy body dementia with Lewy bodies, and that's because they have the dementia first, and then they experience the Lewy body symptoms. But then there's people that have Parkinson's disease, and then they get the Lewy body after. So it's all in the timing of when the Lewy body and the Parkinson's disease kind of meet each other, is how they diagnose it as either dementia Lewy body or Parkinson's disease dementia. So they have changes in thinking and reasoning, confusions, they have slower gait and what we call Parkinsonian movements, which is that hesitation in the gait that you may see with people with Parkinson's. And again, they have trouble interpreting visual information, which is why they have visual hallucinations. They also may have malfunctions in the autonomic nervous system. So they may have a drop in their blood pressure because our brainstem regulates that. It also helps regulate our GI tract. So they have a lot of constipation and bowel issues. So anything that's autonomic is going to may malfunction. The diagnosis, there is no medical test. It's based on the patient's history and psychological exam and their physical exam. And most diagnoses will include probable Lewy body dementia. I'm going to skip over this because I kind of explained that already. And I know we're kind of looking at some time here, but really just know the timing with Lewy body disease dementia and Parkinson's Lewy body is really the timing. If it is which comes first, the movement or the dementia. The difference between Alzheimer's disease and Lewy body is memory is first with Alzheimer's, and movements and changes in behavior is more frequent with Lewy body. Okay, our last one is frontal temporal dementia. Frontal temporal usually affects younger people under 60. I know Bruce Willis is older when he was diagnosed, but it can happen, but most commonly with people under 60. It's the second most common cause of early onset dementia with Alzheimer's disease. and we're looking at about 15 to 22 per 100,000. And about 50 to 60 Americans are affected. Just to go through this very quickly, because I want to talk a little bit about dealing, not dealing, I shouldn't say that. That was kind of a poor choice of words, but helping people with dementia. With this frontal temporal, there's variations of it. There are variation where they have language problems. There's a variation where they have speech problems. There's a variation where they have movement problems. Bruce Willis has the language problem, so he lost his ability to communicate with language. So that's those the different types. It is typically there's a family history in about 15 to 40%, and at about 10 to 30%, you're going to see an autosomal dominant pattern of inheritance. So it is the most common feature is the accumulation of certain neuronal proteins in the brain. One of the things that I want to talk about here is Reisberg's theory of retrogenesis in any of these dementias, and that is a theory that this neurologist, Barry Reisberg, thought made sense to him, and it was, I have to tell you, it was my aha moment for me. And what it says is the concept is reverse development as one ages into dementia. So we use age comparison to better understand Alzheimer's disease dementia. It's used mostly with Alzheimer's disease because it has, it's a pretty predictable path. But excuse me, what he's saying in this is the stages of development from birth to, infant to toddler to young child to adult, older child to adult, has the same pattern in reverse when we have Alzheimer's disease. Now, do we treat a person with Alzheimer's disease as a child? Absolutely not. But what we do is use that information that maybe the early part of dementia matches up with the cognition of a 4-year-old, and that helps us understand why that person with Alzheimer's disease may be behaving the way that they're behaving. For example, if you don't give someone who is 5 years old, you don't give them what they want, they're going to scream and have a temper tantrum. And so we know that a person with Alzheimer's disease who's in that middle stage dementia might get angry or have a behavior because that's their way of communicating. So it's all about how we communicate, understanding what that person is experiencing. But we never use that Reisberg theory of retrogenesis to treat someone like an infant. One of the things that we talk about when we're working with someone with dementia is meeting them in their world, understanding what they may be experiencing, walking side by side and living in the moment with them, because that moment is going to change and they're going to move on to something else in another moment. So we really have to understand that what they're experiencing right now, whether it be they're angry, they're frustrated, we have to try to understand why that is. It's very difficult to understand a person living with dementia when they can no longer communicate with you, because they will, in most of the dementias, lose their ability to communicate verbally, as we know. So they're going to communicate their needs differently, and their needs that need to be met can be many things. It could be maybe they're hungry, maybe they have to go to the toilet, maybe they're tired, maybe they're lonely. There's a lot of reasons. Maybe they're cold, maybe they're hot. We call these triggers. And these triggers will change their behavior. And why? They're trying to communicate with us because they can no longer communicate. How does a 2-year-old that can't speak or maybe a 1-year-old, let's say, that can't speak, but they want something, they're going to communicate that to you non-verbally, and it might be in the form of a behavior or an action. And because these people can no longer talk anymore, that may change what you're experiencing with them. So, because in order to communicate, you need to have two people that are cognitively intact. One is sending the message, and one is receiving the message. But if someone who is not cognitively intact can't receive the message or can't give the message, we're going to have a problem. And so we have to be kind, we have to be tender, we have to try to understand what they're saying to us. Demi Moore's message, I think, is important because it gives us the understanding that we have to live in the moment with them. So let's listen to her message.
We're struck. You're very modern in your relationships, and I think it's really touching. And you talk about helping people, and I'm just curious, it just crossed my mind. I know how close you are with Bruce Willis and his family. What message do you have for people out there who have family members who have dementia, who are maybe caring for them or in their lives?
I think the most important thing I could share is just to meet them where they're at. And when you let go of who they've been or who you think they are, who even you would like them to be, you can then really stay in the present and take in the joy and the love that is present and there for all that they are, not all that they're not.
That's beautiful.
Thank you.
Yeah.
So that's our message that we'd like to leave you with too, is today takeaways from us is most people who are diagnosed with mild cognitive impairment can live independently with support. And as it progresses, support will need to be amplified. Not everybody who has mild cognitive impairment will transition to dementia. Remember that dementia is that umbrella term. For us, improving our overall health, our nutrition, exercise, doing those cognitive games really may stave off forms of dementia. Watching TV does not count. You're a passive person when you're watching TV. You need to engage in something. We know that early diagnosis will help you get medications and support that you may need to delay some of the progression. And new tests and medications are available. And there's new ones on the horizon. You saw that one screen and all the stuff that they're doing in dementia. And I'm hoping that with the changes in doing research, we won't stop doing research on this. And remember that if you've met one person with dementia, you've met one person with dementia. Walk side by side with them, be there for their support, and try to, like Demi said, they're not the person that they were 100%, but they're still that person. They still have their personhood. They still are going to want to be loved and want to connect with other people. So thank you for joining me today.